Hi, everyone. Welcome. So pleased that you could all join us this evening. My name is Janine Dyer, and it is my pleasure to introduce our speaker for the evening, Dr. Denise de la Nueces. She is a board-certified internal medicine physician, an addiction medicine specialist with a focus on vulnerable populations. She received her undergraduate degree from Columbia University and then went on to Harvard Medical School, where she received her MD in 2008. After that, she completed a residency training, and then she was granted a Commonwealth Fund Mongian Fellowship in Minority Health Policy and completed a Master of Public Health degree in Health Policy from the Harvard School of Public Health in 2012. That same year, she joined the Boston Healthcare for the Homeless program, and she now serves as the Chief Medical Officer there, and she is also an Assistant Professor of Medicine at Boston University School of Medicine. She's been a part of our program for a number of years, and we're so pleased to have you here tonight. Welcome.
Thank you so much, Janine, and welcome everybody. Good evening, everyone. I really appreciate your taking the time to to join us for this talk today that will be focused on caring for patients experiencing homelessness. I've been at BHHP for 12 years, going on 13. I have learned quite a lot about caring for people experiencing homelessness in this time. Not an expert. I think it takes a lifetime to become an expert, really. But really excited to share with you all what I have learned in my time at Boston Healthcare for the Homeless program. So I will go ahead and advance the slide deck to just share a little bit more about our program, Boston Healthcare for the Homeless program. I'd like to share that our program has been around for 40 years now. Actually, we just celebrated our 40th year back in June of this year. And our program was founded back in 1985 as one of 19 healthcare for the homeless programs that were funded by the Robert Wood Johnson Foundation and the Pew Charitable Trust at the time, really with the intent of creating centers of excellence and centers of expertise around homeless medicine, and in several metro areas nationwide. Previously, what the U.S. Conference of Mayors and what several individuals and agencies that were really focusing on people experiencing homelessness had noted is that there was a lot of fragmentation of care for people experiencing homelessness. And by that, I mean homeless individuals who were being seen in lots of different care settings, in lots of different hospitals, lots of different clinics, but no consolidation of that care and no one entity that really helped to coordinate all of that care across all of those different sites. And so that's where programs, Healthcare for the Homeless programs like ours here in Boston, really kind of fit in. And that is the void that they are intended to fill. Our mission here at BHHP is to ensure unconditionally equitable and dignified access to the highest quality healthcare for all individuals and, importantly, families as well experiencing homelessness in our community here in Boston. I encourage you all after tonight's presentation to take a look at our website and particularly to familiarize yourself if you're interested in our mission and our work. And I included a link here for those who are interested in doing so. Our basic goals back in 1985, the founders' basic goals for our program were threefold. First, to establish a health services care delivery model that would provide that continuity of care throughout all the different settings in which people experiencing homelessness could be found and in which they could be engaged. So from shelter to the street to the hospital. That's where our logo of a bridge really kind of came from. It's harkening to providing that continuity across the spectrum of all of those care settings. Secondly, to provide care through multidisciplinary outreach teams, really acknowledging the importance of not just providing care through healthcare providers, meaning physicians, nurse practitioners, PAs, but also nurses, also behavioral health specialists, also peer recovery coaches, community health workers, the importance of all of those pieces in order to really be able to provide holistic care for individuals experiencing homelessness. And thirdly, establishing the capacity to meet the needs of homeless individuals, again, across the spectrum of care from street shelter to the hospital. So embedding ourselves not just on the streets, not just in the shelters, in order to engage folks in all of those spaces, but also embedding ourselves within hospital systems such that hospital-based providers could see us as a resource through which to coordinate care for individuals experiencing homelessness. I'd like to share as well a map of our services and just the geographic spread of our program. I think lots of times when people think about Boston Healthcare for the Homeless program, they think of our main headquarters or flagship site, which is located right across from Boston Medical Center in South End, kind of at the South End Roxbury border here in Boston. But truly, historically, our program has had a really much broader reach throughout the city of Boston, as you can see here. This nucleus here again in the South End is where that kind of flagship building is, 780 Albany Street, right across from Boston Medical Center. But you can see that we are also embedded in many adult shelter and family shelter sites in different parts of the city of Boston. Um, and many of these kind of smaller and more farther flung sites are actually sites where we have had a presence for with our family team, so providing care for individuals, for families rather, in family shelters. I will say that this list and this map is from 2019, back in 2020, because of COVID and all of the challenges that COVID brought for our program as well as many other healthcare systems. We did have to consolidate some of our sites, and we are now at 29 sites. We consolidated some of the farther flung sites that you can see here in this map, but I show this purely to help to illustrate what our reach has been as a program in our four decades. All right, so a little bit more about our care model. The following are really some of the crucial principles that are deeply embedded in all of the work that we do at Boston Healthcare for the Homeless program, and it's really kind of like the ethos that we follow as we're considering new programming to help meet the evolving needs of our patients. First, strong patient to provider relationships really being the basis of care. We recognize that for individuals experiencing homelessness, they oftentimes come to us with really negative past experiences of seeking care in the healthcare setting, in varied healthcare settings and in the healthcare system. And because of that, it can make it can render forming the therapeutic relationship and having individuals follow the care advice that we provide in clinical encounters that much harder. If there's no basis of trust because of really poor experiences with the healthcare setting in the past, and of course, one, it's harder to engage them. It's harder for folks to actually make their way into our clinics to be seen because they may feel that they might be treated poorly again. And secondly, if there's no basis, if that foundational trusting therapeutic relationship hasn't been built over time, then folks may be just more predisposed to, or less predisposed to rather, following the advice that we provide in terms of taking care of their care needs. So that patient to provider relationship really is foundational and is core. And we spend a lot of time building that with not only with individual patients, but really with the whole community of people experiencing homelessness here in Boston. We also recognize, as I alluded to before, that multidisciplinary care teams are really essential. 9 times out of 10, what the issues or the concerns that are bringing patients into a clinic to see me or another provider are not necessarily medical or clinical, but rather are based on needs that are best met by a case manager, by a recovery coach, and not necessarily by a provider. So we recognize that in order to meet the varied needs of our patients, and also in order to engage them and continue to positively engage them, that we really have to rely on the expertise of not just providers, but also nurses, behavioral health specialists, recovery coaches, case managers, etc. We also recognize the real importance of integrating our work with mainstream medicine. So again, as I alluded to in our basic principles back in 1985, this remains a real core goal of our program is ensuring this continuity and this coordination of care for people experiencing homelessness across all different care settings. And then the importance of bridging personal and public health. I know that this audience is one that is deeply interested in public health. We here at BHHP, we see ourselves as a real important part of the city and the state of Massachusetts' response to public health, to meeting the public health care needs of individuals experiencing homelessness here in Boston. Another important part of our ethos is making sure that we are delivering care in all of our varied sites non-judgmentally in a way that truly is authentic and preserves the importance of patient dignity. We remind patients all the time that they are the most important part of of their care team. It's not us as the doctors or nurse practitioners or nurses, it's them and making sure that we respect their decisions, even if there are decisions that we may not agree with, that may not be consistent with what we think is in their best interest. We recognize the importance of informing our patients of our recommendations, of the basis behind our recommendations, and allowing them, of course, the dignity of making their own decisions. An emphasis on consumer involvement. By consumers, I mean patients. So we have had over 4 decades here in Boston, we have had a really strong culture of making sure that we engage patients in giving us feedback that informs the care that we provide and the services that we provide. And we actually have a very robust and vibrant patient advisory board, which is what's called our Consumer Advisory Board. It consists of 8 consumers or patients of ours who are actively getting care at our practice, all of whom are homeless experienced, and some of whom, most of whom are now housed, but some of whom are still unsheltered or staying in shelters. And these are individuals who we utilize as experts in sounding boards. If we are considering new programming, we're able to run that new programming by this core advisory board, and they share with us such deeply rich information feedback on how we can tweak whatever we're thinking, our programming, and how we can render it better. So they're really a seminal part, and consumer involvement is really a seminal part of the work that we do. And then we do have an organizational commitment to advocacy in our program. So that advocacy includes everything from publishing research articles characterizing the unique vulnerabilities and needs from a healthcare perspective of people experiencing homelessness here in Boston, to speaking to state legislators and also advocating on the national or federal level around issues and needs specific to people experiencing homelessness. I'd like to pivot a little bit and share a little more about who we serve here at BHHP. So I'd like to first share with you all this data from this year's City of Boston Homeless Census. Now, for those of you who may not be familiar with the homeless census, this is basically a point in time count that happens once for one evening every year, usually at the end of January or the beginning of February. This happens in towns and cities all around the country, where the cities organize groups of volunteers to go and provide and actually physically count the number of individuals who are homeless in the city. That includes individuals who are in shelters. It also includes individuals who may be on the street. So there are teams that are actually go and canvass different parts of the streets of Boston and actually physically count how many people are there for that night. And that also includes individuals who are staying in other settings, such as in domestic violence shelters. You can see here in this little snapshot of the data Two things. First is a column of all of these counts for single adults and then also for families in 2024. And then these counts in 2025 again for individuals and then for persons and families. If we were to compare, if we were to have another column comparing numbers for 2023, what you'd see is that from 2023 to 2024, the total numbers of people experiencing homelessness, as per this count in the city of Boston in 2024, had increased by 10%. And however, interestingly, when we look at the 2025 numbers, we see that in aggregate, there was a change, a decrease of about 4%. And in total numbers of both individuals and also families experiencing homelessness, we see that the total number of people experiencing homelessness, as per this count, in this evening in the winter of 2025 was 5,500. That's the number here in Boston. But I will stress to you all that this is really an underestimate of the people experiencing homelessness in Boston. And the reasons for that I'll get into in just a little bit. But first, I will share again this number, 5,500, and compare that now to who we see at BHHP in a calendar year. And that's about 11,000 people. So in calendar year 2024, our program cared for about 11,000 individuals experiencing homelessness. And just to share a little bit more demographically about the patients who are served here, you can see that the majority of our patients are male. We do have some individuals, about 1%, who identify as transgender in terms of their gender identity information. We also have very unsurprisingly, a very high proportion of individuals who are at or below 100% of the federal poverty level, so 99%. Again, not surprising given who we care for. About 15% or so of our patients are best served in a language other than English. And really the top language other than English that's represented in our patient cohort is Spanish. Since 2023, we've seen also increased numbers of people who speak Haitian Creole as well, really heavily reflected in our patient numbers, although Spanish still remains the top language other than English that's represented among our patient population. And when we look at insurance status, unsurprisingly, because of where we are, the state of Massachusetts, we've had, thankfully, legislature that has historically been incredibly generous in terms of providing public insurance options for people with poverty, experiencing poverty. You can see that about 67% of our patient population is insured with Medicaid. Here in Massachusetts, that's called Mass Health. About 1% are Medicare only. So those are individuals who are on federal Medicare coverage, meaning that they're over 65 or 65 or over. And then so about 17% are dually insured with both Medicaid and Medicare. This category includes individuals who generally are less than 65, but who qualify for Medicare on the basis of other significant medical conditions, such as severe mental illness or disability. We have 11% of our patient population that is uninsured. And these numbers are numbers that we closely monitor. It includes individuals who are undocumented, who are in the state, individuals who we never turn away at our program. We always care for. Those numbers are ones that we are closely watching, of course, and that we fear we do fear that this number may increase in this upcoming year, what with changes to Medicaid policy on a federal level. From a housing status perspective, you see that 40% of our patients are identify as having stayed in the previous night in shelters, but 8% on the streets. And we have 6% of individuals who are doubled up. I'll speak more about this later, but this is basically individuals who don't have their name on a lease, but may be quote unquote couch surfing or staying with friends or family. About 11 or 12% of individuals are staying in other transitional settings, which could include motels or hotels. It could include residential treatment programs for people who are undergoing substance use treatment. And then 6% of patients are in permanent supportive housing. This is really the gold standard, what we want for all of our patients, which is housing where there are supports embedded right on site for patients, including case management and other supports. When we look at the racial and ethnic breakdown, demographic breakdown of our patients, we can see that about 40% of our patients identify as white, and there's roughly around a little bit more than 40%, nearly 50% of our patients who identify as either Latinx or Black. And other groups are represented in smaller numbers. 10% of our patients in 2024 did not have any race or ethnicity documented in our electronic medical records. These are numbers that we're hoping to improve with time. So a little bit more. So I mentioned again that discrepancy between the 5,500 people who were in the homeless census count in January and 11,000 people who we see at Healthcare for the Homeless program in a given year. Why the discrepancy? And the discrepancy is really because we consider Healthcare for the Homeless program, we identify, we define rather homelessness as not just someone who's staying in a shelter or on the streets, but really there's many other settings, housing settings that we consider, or unsheltered settings that we consider homeless or categorized as homelessness. Those include, so just to go through the spectrum here, unsheltered is what people typically think of. So people staying on streets, in tents, in woods, people who are staying in their cars because they don't have housing, or under bridges or overpasses. People often think, when they think about homeless individuals, as folks staying in shelters, so emergency shelters and domestic violence shelters as examples. But as I mentioned, we also include as homeless individuals who are doubling up, people whose names are not on leases but who are staying with family or friends. And in those situations, in terms of how long they can stay, can change, can vary. It may not be set concrete. And then also individuals who are transiently housed, meaning folks who may be staying for a few nights or a few weeks in hotels or motels if they can afford them. Individuals who are staying in jails or prisons, but who anticipate being released into homelessness once they are released from that carceral setting. Individuals in treatment programs, so maybe in treatment programs for several weeks, for example, but anticipate or expect to be released into homelessness once they're done with that treatment. Individuals who are in hospitals, again, who may be in hospitals for some period of time under treatment, but then again would be expected to be discharged into unstable housing settings, and other medical facilities. Importantly, as I've mentioned, we do care for some individuals who are housed, but who may be unstably housed. So they may have a name on the lease, but they may be at imminent risk of being evicted. And those individuals, of course, with housing insecurity are ones that are at increased risk of becoming homeless again, or recurring, or having recidivism back into homelessness. Those are folks who we certainly care for as well in our practice. All right. Just wanted to share with you just a little bit of a visual of what some of these varied living environments look like. So this is in the top left-hand corner here, we have what a typical kind of shelter dorm might look like. This was pre-COVID, admittedly, so there were lots of bunk beds back then. Post-COVID, with efforts to decongest shelters, these beds were often debunked in order to decrease viral transmission in shelters and just decrease how many people were staying in one space at one given time. You can see here in the top right-hand corner some individuals who are unsheltered staying out inside of an MBTA station. So these are often folks who are cared for, encountered by our street team. We also have had patients staying, as I mentioned earlier, in tents or encampments, wooded areas, of course, much harder to find in these settings. And then I just wanted to include, forgive me for not mentioning this earlier, but this is just another picture of another image of what it looks like, of what the inside of a shelter looks like. And you can see here in the bottom left-hand corner, an image of a communal bathroom without any doors, without any doors, because of really the concerns about people using and potentially having overdoses behind closed doors in some of these congregate bathrooms. And this is a typical meal that's provided in shelters. I just wanted to highlight this because food insecurity, of course, is a major concern of our patients and of patients experiencing homelessness in general. You can see here that the typical meals provided in shelters, uh, shelter providers do a great job trying to um, make sure that there is as balanced meal options as possible for shelter guests within, the restricted funding that they get for meals. You can see here, however, meals often may be carb heavy. We have white bread instead of more healthier options for bread. Some veggies here, which is fantastic, but certainly a limited option in terms of healthy options for folks in shelters. All right. So I'd love to just pause and ask folks for some ideas. Let's discuss some questions that I have interspersed throughout the presentation. The first question I'd like to ask is, what impact do you think that these living environments and dietary challenges have on the health of people experiencing homelessness? I welcome participants to please unmute or to enter any responses in the chat, whatever you feel most comfortable with. I think someone unmuted, unless, all right. Well, for the sake of time, we'll go ahead and I'm sure your wheels are all turning. Let me make sure I'm not missing anything in the chat. Oh, yes, let's see here. Thank you. So increasing chronic health conditions such as diabetes, et cetera. Absolutely. Thank you so very much for that. And Paige is also saying, so thank you, Glynis, and guessing that dietary concerns with diabetes are not able to be addressed. Food allergies are also concerns, such a fantastic. These are really great points. Thank you all. So here's a list of some of the medical implications that I've seen, that I've witnessed among my patients who are experiencing homelessness. So chronic stress, as you can imagine, just the fact that some of our patients don't even know where they'll be sleeping the next night. That absolutely manifests as chronic stress, and that in and of itself can have really negative health implications on folks' mental health and also on their heart health and other stress related diseases. Competing priorities, and by this I mean we often have patients who very much understand the importance of taking care of their physical care, of their medical care needs, but their priorities are not making sure that their blood sugar, for example, levels are optimized as a diabetic. Their priorities are often, where will I sleep tonight? How will I make sure that I'm safe tonight? Where will I get my next meal tonight? And so that really ties into the chronic stress of individuals who are experiencing homelessness, and that's understandably because of these conditions. I often say as well that our patients have a really high prevalence of what's called tri-morbid disease, meaning that many of our patients are not only dealing with homelessness and housing insecurity, but also chronic medical conditions like diabetes, like chronic pulmonary diseases, layered on top of behavioral health disease. So think depression, anxiety, and then layered on top of addictions for many of our patients as well, so substance use disorders. And just the challenge is having that tri-morbidity, those three pieces in and of itself for individuals who are housed, it's really hard to navigate. Just imagine how much harder it is for people experiencing homelessness. Exposure during weather emergencies. So think about how exquisitely vulnerable our patients who are unsheltered are during heat emergencies, not having ready access often to spaces where they can cool down and stay hydrated, as well as during really cold snaps in the winter time. And the city does a fantastic job, as does the state, setting up cooling centers or warming centers for individuals during weather emergencies. But for some individuals, for example, those who are staying in the woods, who are unsheltered in other spaces where some of even learning about the ability to access some of these spaces could be a little bit challenging. These are the individuals who are often really at most vulnerable to exposure. Exposure to crime and violence as well. Of course, if individuals are unsheltered, they are at increased risk of being assaulted, whether that's physically, sexually, or in other ways. Trauma as well from all of these pieces. And then medication storage challenges. So imagine being a diabetic and not having, say, in your car, and not having the access to refrigeration for medications such as insulin, and often has to be refrigerated. There are many other examples of medications for chronic conditions that need to be refrigerated, and how challenging it is for people experiencing homelessness to find steady refrigeration for maintenance of those medications. All right, another question I have for you all is, our program has published articles analyzing the main causes of death among people experiencing homelessness here in Boston. We've now published two such seminal articles, the first back in 2003 and another that was published in 2013. My question for you all is, can you guess the average age of death for homeless patients seen at our practice based on everything that I just shared with you about some of the medical challenges of people experiencing homelessness, what you may surmise yourself or what you may have observed yourself or can guess? And then any guesses on the main causes of death among patients at our program? So feel free to chat that in if you'd like. 45, Phyllis, thank you, Janine. 56 or mid to late 50s. 60, 45, fantastic. Thank you for all of these guesses. All right. Well, here we go. So we published a mortality study. Oh, I think there's a few other cardiac in terms of the main causes of death and exposure cause of death. Fantastic. Really great guesses. So we published our latest mortality study at Boston Healthcare for the Homeless Program, was published in 2013. Here's the citation. I encourage you all to take a look at it. It's if you have access to it. If not, I'm happy to disseminate that around, Janine, but it was in the journal JAMA Internal Medicine. And here's what we found. So the researchers at the time analyzed information from a cohort of 28,000 patients who were seen in our practice for a 6-year window of time. And they analyzed what were the main drivers of mortality for those individuals who had passed away in that period of time, as well as the as well as the average age of death at death. And here's what they found. So drug overdose at that time was revealed as the emerging epidemic, was the main driver of mortality for our patients. Drug overdose, mostly related to fentanyl and to heroin. So really opioids are heavily implicated in mortality in this cohort at that time. But cancer and heart disease were the next most common drivers of mortality. Some of you all said heart disease, right on. This information really helped our program to recognize, number one, the importance of deepening our substance use disorder treatment for patients, our addiction medicine treatment for patients, but secondly, the importance of making sure that we really leaned into and continue to focus on the importance of modifying risk factors for heart disease for our patients, and also on cancer screening for our patients. That even as we were focusing on substance use disorder treatment, making sure that we did not lose sight of the importance of routine risk modification for heart disease, as well as cancer screening for our patients. Mortality rates in this cohort were 4.5 to 9 times higher than that of the general public here in Massachusetts in that six-year window. So really profoundly highlights the vulnerability of patients experiencing homelessness. And the average age at death in Boston at the time in this cohort was 51. So again, just exquisite vulnerability, and very much highlights the importance of leaning into and investing into healthcare for people experiencing homelessness. Death again was driven largely in this cohort by complications of substance use and undertreated medical illness. All right, so in the next 15 minutes or so, I'm just going to I will pivot a little bit into that intersection between our program, now that I've shared with you all about Boston Healthcare for the Homeless Program, who we are, what our mission is, what we do, and then who we serve, and the exquisite vulnerabilities of our patients. I'd like to pivot a little bit more since this is a public health focused and highly interested public health audience around how our program intersects with public health, with the public health infrastructure here in Boston to care for people experiencing homelessness and meet their public health care needs. Um, so first, I just would like to state what I think is probably you would think quite obvious, that people experiencing homelessness are at higher risk of acquiring highly contagious infections. And that's for several reasons. I wonder if folks can guess a few of those reasons and pop them in the chat. I suspect you know more. Oh, here we go. Thank you. Close living quarters, absolutely. And group setting, lack of hygiene, beautiful. Thank you so much, Paige and Glennis. All right, so that's exactly right. So crowded living spaces, congregate shelters. You could see, as I showed you here, these um, uh, um, bunk beds, lots of people in really tight quarters. That's true as well for people who are in encampments, even if it's outdoor encampments, just the sheer congregation of people, many people in small spaces, absolutely. For certain infections that are transmitted through viral particles and the like, absolutely increases the risk. Um, Decrease in inconsistent access to public restrooms and showers also really renders people experiencing homelessness exquisitely more vulnerable to acquiring infectious diseases that are transmitted through poor hand hygiene, through fecal mouth contamination um, as well. And the reality is that access to public restrooms and showers for individuals experiencing homelessness in all cities is very, very limited. And the city of Boston does a really great job, as does the state, in trying to increase those access. We, as a community health center and as an organization, also have some access to public restrooms and spaces, but it's quite limited by and large for people experiencing homelessness. Other factors that are related to spread of infections include just habits that may be common in people who are living in these spaces, including sharing of cigarettes, sharing of drinks, sharing of drug use supplies. And then again, imagine for folks who are unsheltered, for folks who may be staying in cars or maybe staying in encampments or in wooded areas, even if there are public service announcements about emerging public health risks, um, that information is often they often don't have easy access and ready access to those types of public service announcements. Just imagine, for example, in the early days of COVID, when those of us who were housed had access to internet, to Wi-Fi, to TVs, to radios, we were inundated with information as the world was learning it. That becomes that much harder for people who are living in some of these more remote, unsheltered spaces. And then at times, limited engagement with medical care, right? So very, very challenging for folks who are who are unsheltered, folks who are also actively dealing with and managing and coping with really severe mental illness, as an example, just how challenging it may be for them to have it together enough to keep an appointment, have it together enough to, when they go to an appointment, to be able to even follow up on the recommendations that were made in the appointment in order to manage their care. And that's where organizations like ours, BHHP, that's where we come in to help to be able to do that engagement, to provide that education from a public health perspective, to really penetrate all the spaces where our patients may be, as much of them as possible, so that we can kind of bridge that information gap for people experiencing homelessness. I'd like to share again a little bit more about specifically here in Boston and Massachusetts how our program has collaborated with public health entities. So we have worked historically since at the very beginning of our program really closely, very collaboratively with our Boston Public Health Commission, so the City of Boston's Public Health Department, as well as with the state's Department of Public Health. And usually how it works, how this um, uh, collaboration works, it's really bi-directional open communication. So when we see something, for example, we're seeing multiple cases of, of a disease that could be infectious in our community, we have ready access to be able to feed that information back to the public health department. And vice versa. So when local and state public health departments identify outbreaks as they're getting reporting from all different healthcare providers and hospitals and in community health centers and other settings are reporting reportable infectious diseases and cases of them to the local public health departments, if they learn that there is a trend of these cases among people experiencing homelessness, then they have historically fed that to us to ask us to really ask us to become partners in that sleuthing and trying to figure out why is it that there are these increased cases of of said disease among people experiencing homelessness. What are you all seeing since you're boots on the ground at BHHP? What are your care teams seeing? And how can what we're seeing at BHHP help to inform the public health department's response? And also, how can we deploy our boots on the ground care teams to actually help with the response? And I have two examples that I'd like to share with you in just our remaining minutes about this collaboration. The first is a small but important outbreak of hepatitis A among people experiencing homelessness. So before I talk about the actual outbreak that happened in 2018, I just would like to share with you all a little bit more about Hep A for those of you who may not be familiar with this. So this is a highly contagious virus that affects the liver. Um, Sometimes it affects the liver and people don't feel badly at all. But in people who do develop symptoms, they usually develop them about 2 to 7 weeks after being infected or exposed to the infection. Symptoms usually last less than 2 months, although that can vary, can be as long as 6 months. And symptoms include jaundice, so yellowing of the skin and eyes, decreased appetite, GI symptoms such as nausea, stomach upset, abdominal pain, dark urine, light colored stools, diarrhea, fatigue. People just feel really crummy, and it's because of the infection in their liver. Importantly, so Hep A is transmitted through like the fecal oral route, meaning that when someone who is infected with this, let's say uses a restroom, has diarrhea, they don't properly wash their hands, and then they go out and touch surfaces or prepare food, and that those surfaces are then touched by others, or that food is eaten by others. That's how it's transmitted. Um, Thankfully, this virus can be prevented. The beauty of public health, it can be prevented through vaccination with the Hep A vaccine, and also it could be prevented through behavioral health measures like good hand hygiene for people who are infected until the infection clears. So what happened in 2018? In 2018, there were several cases of this virus that affected homeless individuals here in the city of Boston. Boston Public Health Commission data revealed that by September of that calendar year, 60 people experiencing homelessness were infected with Hep A here in Boston. And most of those people were people who were actively using drugs by injection. The demographics, the demographics or the demographic breakup of the cases were as follows. So mostly men in age between 20 to 40. A majority of the cases were among people, again, who were using drugs actively. 93% of the cases were sick enough that they had to be hospitalized. And 79% of the cases were found to be co-infected with hepatitis C virus, so another hepatitis virus that infects the liver and attacks the liver, and 9% were co-infected with HIV. So I'd like you to imagine that you're the head of a healthcare center that is caring for people experiencing homelessness like ours at BHHP. When this Hep A outbreak hits, how would you mobilize your health center to respond and to collaborate with the city public health department to help to hopefully quell this outbreak? I encourage you all to share in the chat. Let's see here. Rachel, I missed your earlier comment. Thank you. So any thoughts on what you would do? How would you respond? Case finding, absolutely. So thank you, Phyllis. So trying to identify the cases and interviewing them, trying to figure out exactly, what potential exposures may have been. Education, fantastic. Thank you, Phyllis. Well, I'll share with you all what we did at BHHP, and that's the following. Um, we realized number one, that really importantly, we needed to make sure that our patients were aware that there was an outbreak actively happening and that people who they were coming in contact with their peers in whether on the streets, whether in the shelters, um, may be infected, and making sure that they understood number one, the fact that this was happening, number two, how this virus is transmitted, and number three, what they could do to protect themselves, as well as number four, what symptoms or signs to look out for so that they know that if they develop them, they should go and come to our clinics to seek care and a diagnosis. We also launched a vaccination campaign. I shared with you all that through the wonders of public health, Hep A is preventable through a Hep A vaccine. And we wanted to make sure that we informed our patients that this is vaccine preventable and that we offered it to them, as many as we could. So we deployed several nursing teams at flexible hours, day, nighttime hours as well, to really try to decrease barriers to access of that vaccine. And really, we embedded these teams in shelters. And we also deployed our 3-team providers with the knowledge about this outbreak as well as vaccines so that we were offering this vaccine to as many of our patients as possible. We also made sure, of course, to educate our providers, our nurses, anyone in our practice who was coming in contact with our patients, that this was happening so that at the point of contact, if a patient, let's say we're coming into our foot care room for foot care, even though they were there for that specific purpose of foot care, we wanted to make sure that that nurse or that provider who was seeing that patient was using that opportunity that the patient was in front of them to educate them about the Hep A vaccine, about the Hep A outbreak, and to offer them vaccine in an opt-out way, meaning that let's say a patient were coming in to see me for a unrelated issue. I would say, hey, you're due for some primary care pieces. And by the way, there's a Hep A outbreak. I'm going to go ahead and give you a Hep A vaccine unless you decide that you'd rather not have it. Here's why. So that's the opt-out method rather than saying, we'd like to give you Hep A. What do you think about getting it today? It's slightly different. It's opting out versus opting in. But what we've noticed is that having an opt-out framework of an approach to offering many of our primary care interventions, such as vaccinations, really makes a big difference through that slight difference in approach. Now, with all of these efforts, by the end of the calendar year 2018, we had a total of 3,500 unique patients in our practice who had documented ever received the Hep A vaccine, which is fantastic. And we had an additional 406 individuals who had documented immunity based on serum blood testing. So I think this campaign, in collaboration with the commission, was really successful and helped to quell those Hep A cases and to thankfully decrease the outbreak and put a stop to that outbreak over time. The second outbreak I'd like to share in the last few minutes is just COVID-19. We don't have to go into this in detail because we all lived it, but I did just want to share, of course, what our program did in collaboration with the Commission and the State Department of Public Health around COVID. You all know about COVID and how it's transmitted, and this was our response. So we launched massive, we actually built a lot of infrastructure around screening and testing to make sure that we were aggressively really testing patients who had any symptoms that may have been consistent with COVID early on. A big tenet of our approach, of course, was isolating any cases, especially those cases that may have been coming from the shelter, in order to decrease spread within the shelters. And quarantining exposed patients was a big part of our response early on in the pandemic. Just a picture, a visual here of our testing booth that we built really quickly and erected right in our back in our parking lot to, again, really have decrease the access or decrease the barriers rather to testing for our patients. Here's some pictures, some visuals of our the isolation and quarantine tents that we erected in collaboration with the city and the Boston Public Health Commission and the state, right again in the backyard of one of the large shelters here in the city of Boston. In the early days. And then later on in the spring of 2020, the city and the state were able to get funding from the Federal Emergency Management Administration to open up a field hospital in Boston, a 500-bed field hospital. And our program contracted with the city to run and operate half of those beds. So a really huge intervention and a great example of how our program was able to collaborate with the city and state on meeting the public health care needs of our patients. All right, I'm going to stop there. I believe we have about 5 minutes. I'm sorry, we only have 5 minutes, but 5 minutes for any questions. But I want to thank you so very much. And for all of you in high school, it's fantastic that you're interested in public health. This is such a fantastic field. It's been under, it's had a lot of challenges, under assault in many ways over the course of the past several years. So it's really wonderful to see you all really excited about this. And I hope that this inspires you to potentially be interested in working in homeless medicine spaces or homeless public health spaces in the future. Thank you. I'll stop sharing. Thank you, Paige. Okay, so can you explain the challenges of mass incarceration that we often hear in the news so often? Sure. So mass incarceration is this response or this answer on this question, honestly, deserves a response that's much longer than the one that I'll give right now. But mass incarceration has become, for lots of reasons, excuse me, including the fact that treatment services for individuals experiencing homelessness with substance use disorders in other parts of the city, like in Long Island. Oh, excuse me. Those services are no longer available in those spaces. And the fact that there's so much centralization of a lot of homeless services and shelters, homeless healthcare services in and around Mass and Cass, I think over time, really since 2018, we've seen an increase of unsheltered individuals in and around that space, many of whom are also actively using. There are lots of challenges there. Number one is figuring out how we can provide healthcare safely, provide healthcare and to those individuals, as well as addiction medicine supports for those individuals, helping to ensure that we provide harm reduction services for those individuals as well, so that they stay safe until they're ready to seek recovery or to start along the recovery pathway. But then there are also really significant public health or public safety concerns that have been voiced by neighbors in the neighborhood, by small business owners in the neighborhood, all of which are very incredibly valid as well. I think the city is doing a fantastic job of really, really trying to balance all of those pieces of public safety concerns and also try to identify solutions that are public health focused to those really valid public safety concerns. And of course, on our perspective of Healthcare for the Homeless program, we are advocating that the city continue to involve programs like ours so that we can be part of devising the solutions and ensuring that they meet the healthcare needs of our patients. We also are encouraging them to really include patients, so include the individuals who are impacted, the consumers, the folks on the streets, as much as feasible, so that they can be part of the solutions. Happy to answer any of the questions. And thank you, Paige, for that question. Again, that's a presentation of its own. Thank you, Carrie, and thank you, Glynis.
Thank you so much. If there are no other questions, we are just about at 8 o'clock. So I want to thank Dr. De Los Nueces so much for joining us. Such an interesting and engaging talk to our group. Thank you all.
Thank you so much, everyone. You've been amazing audience at 8 o'clock at night. So really appreciate it. And have a great rest of the evening and take care. Thank you, Janine.
Thank
Bye-bye.
you.